I'm going to talk about, I'm going to talk today. The title I'm known for sometimes being snarky, so I decided to talk about this one called "Getting Real" about antipsychotic related weight gain. Here's why. To preface this, my entry into the profession of psychiatry occurred just around the time that the first atypical antipsychotic drugs had been coming out. So I certainly saw the marketing and the evolution of this medication class and the evolution of thinking around things, and I've gotten very interested over the course of my years in um, in the relationship between industry and the profession and how one influences the other. And it's a lot more complicated, nuanced, and subtle than just drug reps giving you free things. But this story of antipsychotic related weight gain partly touches into this very interesting and complicated relationship between industry and prescribers. It is a very common problem that seems to be now recognized very well, but doesn't seem to have a very good solution. And this is a gigantic concern because weight gain goes along usually with other things like glucose levels rising, insulin response becoming less responsive, blood pressure going up, and inflammation happening. And all these things are collectively called metabolic syndrome. And so it's not just the weight itself doesn't kill you, but the things that are associated with the weight gain, like the high blood pressure and the elevated glucose levels, over time can seriously damage the fragile tissues like small blood vessels, kidneys, eye tissue, and so forth. And that can spectacularly reduce the lifespan or introduce opportunities for things like heart attacks and strokes. And so weight gain is a big deal. And the why I you might tell that I'm a little bit animated as I speak about this because it strikes me as a really big oversight on the part of the medical profession to have introduced these drugs and have formed a prescribing culture in which these drugs are the top first line default recommendation, and not having trained clinicians in effective ways to prevent weight gain and to stop weight gain and to reverse weight gain. And so I'm going to talk about that issue specifically. Well, I've sort of alluded to why weight gain is bad. And to understand how to intervene, I'm going to touch into why, how we think these drugs can cause weight gain, because you can't really solve a problem unless you can understand the problem to some extent. And I will tell a snarky story about why lifestyle interventions are probably not nearly as effective as we would hope that they should be. And I'll talk about why medications probably ought to be more commonly considered, and not just considered, but probably prescribed when necessary. So going back to why obesity is a problem, a lot of this probably you already know. Nobody likes to be obese. It is very stigmatizing. It still it strikes me that in our culture we've moved in a lot of ways to try to not or cut down prejudice, discrimination, snap judgments based upon appearance, and we're making progress in many areas. But when it comes to weight, there is still tremendous permission for people to have prejudicial or stigmatizing or discriminating attitudes against the people that have overweight or obesity. And one of the reasons why the second generation or the so-called atypical antipsychotic drugs became preferred is because it was thought that we may be able to prevent the occurrence of tardive dyskinesia. And tardive dyskinesia was seen as a very good thing to avoid because it is known that it can be irreversible and disfiguring. Irreversibility of tardive dyskinesia may happen between 20% to 50% of cases. So, as an aside, tardive dyskinesia is not always permanent, but in a significant portion of cases, it can become permanent. So with the mindset of let's try to not induce a permanent and disfiguring condition, we prioritize second generation drugs. Yet for many people, obesity, once established, is a permanent and disfiguring condition. And the consequences of obesity include damage to your joints, damage to your skin, damage to your blood vessels, damage to your heart, stroke, and diabetes. And those things are not only irreversible and potentially disfiguring, they're also life shortening. So it seems really odd in this light that we defaulted to this category of medicines to try to prevent a possibly permanent and disfiguring neurological side effect, which, by the way, now we can treat. And instead, we're introducing risks for lots of permanent and irreversible and sometimes lethal side effects. By the way, lethal, that word, I mean it. The thing about killing people with medications is that it happens in slow motion. So we don't really, nobody makes a connection between Zyprexa and killing somebody, even though that person is now at a significantly increased risk of 15 to 20 years of shorter lifespan. Because it doesn't happen right away, there's not immediate cause and effect, we don't appreciate the potential danger of a drug like, well, insert your drug. So that's a thing. Da, 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 da. And let's go on to the next slide. Mechanisms of, I tell medical students that I tell anybody who wants to listen, actually, if you want to get a Nobel Prize, then figure out the relationship between metabolism and psychosis and schizophrenia, and that will be the way to do it. Because there is a massive, rich, and very interesting literature going back to the early 1900s, where it was recognized that people with what would be called schizophrenia, in Kraepelin's term, dementia precox, they don't use as much oxygen as people without that condition. They could measure oxygen consumption in 1910, and people with schizophrenia didn't burn as much oxygen, meaning that they didn't have high metabolism rates. And the beauty of a study like that is that there's no possibility of contamination or artifact by medication treatment. So it also is interesting that the clearly the most effective antipsychotic drugs, clozapine and olanzapine, are clearly the ones that have the highest risk of weight gain. And in people with schizophrenia, if you look at their relatives, you will see a significantly higher proportion of individuals with type 2 diabetes than you would expect from the general population. So there's this interesting intersection of narratives about metabolism, weight regulation, psychosis, and psychosis treatment. And I think that none of this is really well understood, but to the person who can, tie all these things together in a verifiable way, that's going to be a massive breakthrough. So if you want a Nobel Prize, I would say that you could focus on that. These drugs, the second generation antipsychotic drugs, have a lot of interactions with a lot of different receptors. In pharmacological terms, we call them dirty, because as opposed to just interacting with one molecular target, which would be a narrow spectrum or a clean or a pure drug, the second generation antipsychotic drugs interact with a lot of different neurotransmitters. For example, histamine, dopamine, serotonin, acetylcholine, and norepinephrine, and more. So they have multiple neurotransmitter interactions, and some of those interactions are on tissues which are involved in the regulation of energy, regulation of glucose levels, storage of energy in terms of fat. So multiple sites in the body, multiple receptors, and so there's lots of opportunities for disrupting energy metabolism. The low-hanging fruit is with histamine blocking. Most of the antipsychotic drugs are histamine blockers, the way that Benadryl would be. And if you block histamine in the hypothalamus, it turns on your appetite. So the simplistic hypothesis is simply, if we have a little bit of extra calories per day, like 150 calories per day, and we're a little bit less active, like 20 minutes of walking worth of activity, then you can wind up with a calorie surplus, and relatively small surplus of 150 calories a day over a year translates to the energy equivalent of 16 pounds. So that's a simple theory, and probably some aspect of this is correct. However, when people start these antipsychotic drugs, they gain weight rapidly, and it's not like a linear slow growth as one would expect. So there's something significantly in addition to simple calorie math which is at play. And as an example of rapidity, these are some, in my view, alarming studies where a test dose, a test exposure to healthy volunteers 9 days at a moderate dose of olanzapine resulted in a significant disruption of insulin signaling. And when insulin levels rise, that's what hyperinsulinemia is, fat is stored. Insulin is a hormone that signals to cells that we need to store glucose in terms of in fat molecules. And that short-acting significant disruption of insulin, it has been repeated several times. And as well, other hormones such as leptin, which is a satiety hormone, and triglycerides, which is a measure of both insulin signaling and glucose levels. So these disruptions are, I mean, the insulin rise is not related to weight gain. The insulin rise clearly is preceding the weight gain. And just a hint at the mechanism and the speed of it. Okay, let's talk about preventing. So we should, well, okay. First, let's not start the problem. Let's try to just not make it happen. So we don't necessarily need to prescribe antipsychotic drugs to everybody. It seems to me that at least half, if not 75% of people with bipolar disorder are on second-generation antipsychotic drugs. And so they are given both a weight gain risk and a tardive dyskinesia risk, which may be, those two risks may be unnecessary, considering that for bipolar disorder, that the classical anticonvulsant mood stabilizers are really effective and have much lower weight gain risk and no risk of tardive dyskinesia. So it's an interesting, and going back to the marketing, the interaction between industry and the profession, I don't think it's an accident that we have many patented second generation antipsychotic drugs, and we have, like, the majority of people with bipolar disorder are on them. And it's not clear to me that that the benefit of being on olanzapine outweighs is superior to lithium or Depakote in a way that justifies the additional diabetes risk, for example. And in treatment-resistant depression and in many conditions that are not psychotic, they're used. And in depression, my gosh, there are so many opportunities for effective treatment in evidence-based psychotherapy, for example. In my world, I spent like 10 years working with complex depression patients. And as an anecdote, every single person I would ask, I would say something along the lines of, do you have a purpose? Do you have a sense of purpose and meaning in your life? And no matter how I tried to phrase the question, none of the people that I saw who had years of non-response to medications had any idea what I was talking about. They could not articulate that. And when I would ask them about their therapist or their psychotherapy, they would almost always say, yeah, I see somebody, I've seen this person for 4 or 5 years. And I say, what happens? Well, I talk and they talk to me. So none of the people that I saw could, and I actually fished out, I tried to ask well, what I would do is I would say, I'm glad that you have this good relationship with this therapist. Tell me, has your therapist explained to you, like, in psychological terms, what might be contributing to your depression? And, in what ways might your therapy be trying to address these environmental or psychological or, belief systems? And again, my sample was people who had failed many treatments, but nobody that I asked that question to could describe psychotherapy in ways, or their experience of psychotherapy in ways that had given them a psychological understanding and psychological techniques to get better. Most of what they were describing to me sounded like supportive listening or befriending of some sorts of things, which is nice, to be clear, and works for many people with moderate depression or adjustment disorders. But for more serious depressions, we need more serious and evidence-based treatments. And again, so many of the patients that I saw had been on antipsychotic medications to augment their antidepressants, and meanwhile, the real psychotherapy seems to have not been part of their equation. And also, as a plug, I'm probably going to have to go quicker later on, but to this audience especially, I want to emphasize this, that in my work as a depression specialist and an electroconvulsive therapy provider, I would see people whose lives were hollowed out for 2, 3, or 4 years, because of severe depression. And during that time, they were given medication after medication after medication in doses that exceeded dosing guidelines in combinations that had never been combined before. And so many of these people, and of those with melancholic depression, literally 95% of those people, I would get fully restored, fully remitted in 3 weeks with electroconvulsive therapy. And so that again makes me a little bit angry because I'm like, I believe people should be given the best shot at an awesome life and treatment should work. And it seems like, spending 2, 3, or 4 years with various kinds of treatments or therapies and, not referring a person to ECT, which again, remission can occur in a 3-week time frame, it's mind-blowing to me. So to this group, I will, maybe I'll come back and talk about ECT because maybe it's worthwhile, but it is a spectacularly miraculous technique for the right kind of person. And it is not in any way looking like what was depicted in the movies. It should be, if we're interested in like having people thrive and being free from depression, we should probably keep brain stimulation treatments closer to top of mind.
Correct.
So we can prevent weight gain by simply not prescribing medications when we can do without them. And when we do need medications, we could choose medications that have the lowest possible risk. So many medications have been analyzed and not all have the same degree of weight gain risk. Here we're looking at an effect size with to the right of the vertical 0 line means increasing weight gain. And there are the olanzapine, clozapine. All these drugs are significantly higher weight gain risk. And there are drugs like Geodon or Haldol or Prolixin, or I mean, those are probably the best ones. And to a lesser extent, aripiprazole. Actually, I see aripiprazole is probably a lower end of the middle tier. So, but we can certainly prioritize the medicines which have the lowest overall risk. So now let's talk about if we have to prescribe medications, how can we, mitigate the risk? How can we prevent it or reverse it? So every single person says we should have diet and exercise, and these interventions do work for many people. If you go to medical literature and try to search for the evidence for diet and exercise interventions to reduce the pace of weight gain or to mitigate weight gain, you will find many studies that show that it helps. However, please keep in mind that there is very much a selection bias going on in those reports. The only people who are signing up for those diet and intervention studies are people with psychosis who, one, have the capacity for informed consent to sign an informed consent form for a research study, and two, are actually interested in being in a research study, which is going to look at diet and exercise. And in the research study, they're going to get a significant amount of extra attention through study coordinators. So it's not a natural environment, and it is pre-selecting people who are perhaps more likely to succeed. So that's to be clear, reducing and so me and my friends, we can hire personal trainers, we can have gym memberships, we can get foods sent in to us and ask me and my friends how much weight we have managed to lose and stay lost. And you'll find that me and my friends probably give you sheepish answers like, well, it's really hard. So point being that even people who have good resources and no mental illness have a very difficult time of achieving significant weight gain and keeping that weight off over the long term. It's a very difficult thing to do for people with good resources and good brains. Now imagine that I have impairments of my cognition due to psychosis. I have difficulties with my mood, I have body-wide problems due to my mental illness. And on top of that, my doctor is prescribing medications which are pharmacologically and unnaturally stimulating my appetite and simultaneously changing my insulin in ways that prioritize fat storage. How's that going to work? So it's not a fair fight. And the reason why we keep doing this, why doctors keep saying eat less and work more, is because doctors are not trained, psychiatric doctors especially, on how to manage this problem. And we can get into why that happened, but it's a simplistic answer which doesn't always work. And here's an example of why it might not work in real world. Locked hospital ward, the people on antipsychotic, starting on antipsychotic drugs in a locked ward with pre-measured meals, with an adequate energy metabolism, exercise equipment on site, all staff trained to, we're going to try to prevent weight gain. So it's difficult to imagine probably a better environment in a natural world scenario for showing the efficacy of diet and exercise in a structured, controlled environment. And here's what the results of this study were: looking at weight gain over the course of 90 days. Or that's not weight loss, that's actually weight gain. So this is a spectacular fail of a very well designed, thoughtful program that ought to have worked, and it didn't. So that's because going back to this interesting, mechanism of action thing, it's a whole lot more than just, calorie in, calorie out happening here. So again, if you want Nobel Prize, then focus on that thing. So we should still, I recommend, healthy diets and exercise because they're inherently good, useful for mental health and health promoting. I'm not dismissing the value of that, but as a solution to weight gain, it is not, there's a significant opportunity for failure. So now to super quick go through some options. We ought to prescribe medications, and probably ought to do so more readily and more aggressively. Of the medications we can choose, here's one called metformin. It's a very old medication. It's been in use in clinical practice since the 1950s. Not so long in the United States, but still, 30 years. It's based on a natural product. It's derived from a natural product, and it does many things that are relevant to the distortions that these antipsychotic drugs can provide. For example, the insulin disruption, the glucose levels, and the appetite. And key point, metformin is approved for the treatment of type 2 diabetes. And a common fear that I hear is that, well, if we give a diabetic medication, there might be a risk that we crash their blood sugar the way that you would with insulin. Metformin is like, that's almost a zero risk drug. It's not going to happen. If your glucose tends to rise because of metabolic syndrome, then metformin can help to keep it from rising and bring it down to a normal level. But taking metformin is not going to cause hypoglycemia and have a glucose crash and all those things that happen with it. For people, caveat, there is no such thing as a safe drug. So even though I'm going to say metformin is relatively safe, emphasizing relative. But for people who don't have significant mental illness, in other words, for the majority of people who are entering first episode psychosis treatment programs, who have good physical health, who specifically don't have bad livers and bad kidneys, the metformin is a fairly, relatively safe drug, and it seems to work. Here are the results of 18 different randomized controlled trials in aggregate, looking at 1,200 people. And here's study by study, line by line. Again, 0 on this graph means that there's no effect whatsoever. If the lines are to the left, then this means that the people were tending to lose weight. And if the line doesn't cross, if these horizontal lines don't cross the vertical line, that means statistically significant reduction of weight. And overall, if you average all, there is a coming to an effect size of nearly 0.7. That's pretty good. And so one now wonders, if we had 18 studies and 1,200 subjects and it seems to work, why are we not told as prescribers, prescribe metformin when you need to? Good question. And that's a talk for another day. But interestingly and amazingly, in 2004, at the end, came a group from UK who did in fact have a consensus validation and developed a guideline and published it in the premier academic journal for schizophrenia research. And they in fact say we should prescribe metformin. They say for people who are prescribed olanzapine or clozapine, we probably ought to immediately prescribe metformin. For people who are taking a drug that is like when in their term medium risk for weight gain, then you may immediately co-prescribe metformin if they have already some hints of metabolic syndrome. And for those that don't have hints of metabolic syndrome, then if they gain more than 3% of their starting weight, which is gain but not excessive gain, as basically the first sign of weight gain, then yes, we should prescribe metformin. And similarly, people who are on the lower risk drugs, anybody who's gaining 3% of their body weight should be on metformin. That's their recommendation. Finally, somebody has put it into writing. Also, GLP-1 agonists, I'll talk next. GLP-1 agonists, these are drugs like Ozempic and Wegovy and Saxenda and so forth. They actually, they're just being studied a bit. We don't have as much data as here, but the data that we do have overall seems like they probably do work. And when they work, they tend to work really well, it seems. So these are another option that can be considered. And there is evidence to support their efficacy at reversing antipsychotic-induced weight gain. Anecdotally, I had a patient to whom I was prescribing Saxenda many years ago. She was on clozapine and she lost 50 pounds and it stayed off. And so that was very nice. A drug you're familiar with is topiramate, also known as Topamax. There's not, I don't think that it's a primary indication for a psychiatric disorder. It's an anticonvulsant drug, but it has a lot of very interesting psychotropic properties. It also reduces appetite and reduces weight. And so topiramate, 16 trials, 870 participants, and overall a signal for weight loss with that. In a different meta-analysis looking at symptoms, there was in this analysis a tendency for additional improvement of psychotic symptoms with topiramate add-on. So that's a plus. I will caution people on two things, however. I have seen personally, and it has been reported in the literature, that some people will have the opposite reaction, get much worse with topiramate. So even though on average it may be helpful, there are going to be people for whom it's not helpful at all. And secondly, there's in the prescribing information for topiramate a warning not to be on ketogenic diet because that's going to increase the risk for kidney stones and other consequences of overly acidic blood. So, but the point being here that topiramate is another option that seems reasonable based upon the data that we've got. One last comment, olanzapine and samidorphan combination goes under the brand name Lybalvi. The idea here is that that samidorphan is an opioid receptor blocker, and the theory is that people gain weight because they're feeling too much reward from food. So if we block the reward signal, then we're going to block the weight gain. Curiously, that is not was never until that drug came out. That was never mentioned as a mechanism of antipsychotic-induced weight gain. So that's a curious thing. But more importantly, in my view, the weight reduction is not really large if you look at published data. And the most important thing is, as I said in the beginning, it's not the weight that kills you, it's the glucose. And so it's great to not gain weight, but it's important not to have an elevation of glucose because elevated glucose over time does tremendous damage to the body. And there's nothing about the pharmacology of an opioid receptor agonist which should be predicted to help in any way with glucose levels. And indeed, it doesn't appear to be. If you look at the published data on the glucose changes, it tends to certainly not reduce it, and if anything, a tendency toward increasing it. So it's an option, and probably for some people it does reduce weight gain, but there's not strong evidence that it's going to be translating into reducing the glucose problem, and that's the problem that we need to worry about from a health point of view. So in the end, we ought to pay really serious attention, like literally life and death attention, to keeping weight at a healthy level. And we should not prescribe antipsychotic medications when possible, thus emphasizing the role of other modifiable factors like environmental stress, family stress reduction, family education, coping skills, and anything non-pharmacological that can reduce symptoms and stress is going to be a big plus. in that regard. And when we have to use medications, we probably ought to reconsider whether we should default to Invega or Zyprexa and look and aggressively prioritize the lowest possible risk drugs. Diet and exercise are nice and healthy. For some people, they work, but it is a very big uphill battle. And we have to accept the reality that there's going to be an absolute irrelevant intervention for some patients. And we ought to train our trainees to learn how to use these medications because, as they say, if you broke it, you bought it.